Uh, there is a one patient who has a 22 years old and really big the prostate mass. The mass size is about the 15 centimeter and 12 centimeter.
Wow.
All the bladder is already moved up to the umbilicus area.
Yeah.
And we already take the fine needle biopsy from that mass, and the biopsy result did not come up yet.
Yeah.
Maybe in 2 days we're gonna have the histology result. Then I will discuss about this patient. I want to discuss about this patient with you. Is it okay for you?
Of course.
Maybe tonight or tomorrow I will send you the CT scan.
Sure.
Yeah, it's really big mass.
Yeah, that's very big.
Yeah, his PSA level is 87. Only 22 years old boy.
Yeah. Do you think so? When they get that large, I do worry about a sarcoma or one of those other kind of faster growing, faster growing masses or cancers. Really, it's a very tough surgery. And usually, when I tell people about it,
on the CT scan, there is a very high vascularity. And also the full of radiation, that's a really tough one. And I think we will see the histology result and we'll discuss about it, the surgery or the pre-surgery chemo, and we will decide these things.
Yeah, sorry, I think I signed out by mistake. Just give me one more minute. I apologize. To be honest, I think probably just going forward with surgery first to really get, because most of the time these are sarcoma or there's something unusual, right? And so for these, having good tissue diagnosis is very important. So I do think that proceeding that way first is probably better.
Okay, I got it. Okay, it's time to start. We already passed the 9:10, 9:05.
Okay, very good.
Yeah.
Okay, so thank you everybody for Dr. Bayarbatar and for everybody there for the opportunity to present about prostate cancer. And just for Dr. Bayarbatar, do you want me to leave some time for translation, or is everybody, like I know there are different levels of English speaking. Do you want me to just continue, or do you want me to hold off for translation too?
Okay, I think we don't need any translation and you just keep going.
Okay, very good.
We don't need any interruption.
Perfect. So, and I know that you're all very busy. So thank you for the opportunity to present. I will be talking just about prostate cancer to provide a little bit of a background. I'll talk specifically about prostate cancer in Asia and specifically in Mongolia. We'll talk about the surgical management and about some different things that we're learning about advanced prostate cancer treatment itself. And so just to tell you a little bit about myself. So I'm an assistant professor at the University of Pennsylvania in Philadelphia. I did a lot of international work. And in fact, I actually came to Mongolia, this is about 6 or 7 years ago, with Dr. Jay Smith, who is the chairman of the AUA. So this picture here in the beginning is actually me with Dr. Smith. And I don't know if it was Dr. Bayarbatar, if one of the other surgeons were there. This is when we were doing a open partial nephrectomy. This was about 7 years ago, I believe. So around 2000, I guess maybe 6 years, 2015 or so, something around there. So the main thing that, I wanted to explain too is that cancer is increasing in pretty much all of Asia. If we look at this, most of Asia here is either red or orange, indicating that we are seeing more and more cases of cancer, especially with prostate cancer and bladder cancer. Both of those are increasing in how often we're seeing them, but they can also cause significant problems in terms of disability, in terms of how it affects people, but also mortality in terms of survival. The other problem that we see too is that specifically for prostate and bladder cancer, you can have about a 20 to 30% increase in the years of lost life because of those cancers. And so those two in particular can have a very significant impact in the quality of life, but also how long people live. The other problem that we're seeing too is that for both prostate and bladder cancer, we will continue to see an increase of about 50 to 70% in terms of how often patients are being diagnosed with these two diseases. What we know about prostate cancer in Asia is that number one, you don't really see it as often as you do in the States. We know that for most East Asian men, prostate cancer is not significantly high. In fact, the incidence around in Mongolia is estimated to be about 23 per 100,000 compared to about 173 in the United States. What we do know, however, is that even though the incidence, how often you find it, may not be that high, the mortality is actually quite high in terms of how people are surviving with it. And it's often found in later stage disease. In Mongolian specifically, we do know that liver cancer is one of the most common types of cancer that are found. In fact, liver cancer is about 11 times higher risk in Mongolia than it is in the United States. The other thing that was interesting was that Mongolia is actually quite a young country. About 1/3 of the country is under 15 years old or under 20 years old now. So that does mean that later on in life, we will be seeing a bigger population that is olding, but right now it's quite a young population. The other thing too is that prostate cancer screening may be relatively rare. And again, the majority are found or seem to be found with later stage disease with a 5-year survival estimated to be around 70%. When we talk about prostate cancer mortality, and again, we know, Mongolia here, the incidence rates are quite low. Again, everything in blue indicates a relatively low incidence of prostate cancer, including Mongolia. But the biggest problem, again, that we see here, liver cancer, affecting most of the different states within Mongolia, including the central region around Ulaanbaatar. So those are different things that we need to both work on and can work on together for that. So one big thing is that if to really go over is if PSA screening can really save lives. And the answer to that in general is yes. It is important to know that if men have PSA screening, at least if you get it one time, that you can reduce the risk of cancer death by almost about 40%. And so it's a significant decrease if you're able to use prostate cancer screening. That's why the United States kind of stance or their recommendation on prostate cancer screening has changed quite a bit. In 2008 and 2012, they really did not recommend it for everybody. But in 2018, more recently, they did change that recommendation so that doctors and surgeons and urologists can talk about this with their patients more as a whole. So instead of talking mostly about prostate cancer screening or the mortality, I did want to focus a little bit on the actual surgical practice of this and also some of the advanced prostate cancer. These were two things when I was in Mongolia with Dr. Smith that we did spend a lot of time on with the surgeons. And one thing I was very impressed by by the surgeons and by your colleagues in Mongolia is the level of training and surgical expertise that you have there is quite excellent. And really, in terms of some of the other trips and some of the other countries that we've been to and partner within IVUmed, your staff there are very excellent trained. And I think that it was a very good partnership to have together. With that said, the radical prostatectomy is quite a difficult surgery compared to even the radical cystectomy. And the primary reason is that you have to both take out the prostate, but also recreate that urethral anastomosis in a way that it does not impact their quality of life. And that's the big key, and that's the big problem. So the first thing we do is just make a infraumbilical incision going from just below the umbilicus to the pubic symphysis. The first thing we really do is just start with the pelvic lymph node dissection. Again, usually classically and historically, we take the obturator node packet bounded by the external iliac vein, the obturator nerve, and the pelvic sidewall laterally. So if you look here, again, this is the main packet that we go to. When we talk about extended lymph node dissections, there were many papers about this, and the papers seem to signify that going for an extended lymph node dissection may not improve survival, although it does improve sampling, meaning it does help to improve your staging for prostate cancer. One important thing that we found actually is this internal hypogastric area. If you take that lower packet or deeper packet, that does have a significant amount of those positive lymph nodes for higher risk disease. So if you had to extend your lymph node dissection in one way, you may consider trying to get some of those hypogastrics down in the lower area. So again, looking at the pelvic lymph node dissection, really the first thing you have to do is get good retraction of the area, make sure that you can see the bladder and the sidewall well, and then really identify that external iliac vein and take your time to dissect out the obturator nerve. Again, looking at these pictures here, these are the classic pictures that we see from what Dr. Walsh had described, looking at the external iliac vein, the artery here, and then using surgical clips as we are retracting. And the hope is that you would get a really clean packet from the vein boundary around the obturator nerve. And again, you can see the hypogastric complex over there. The next step, this is again, the really important area. Is dividing this area from the puboprostatics to the endopelvic. It really depends on the anatomy. And so, for example, the average weight or the amount of obesity you see in the States is probably a little bit more than what you encounter in Mongolia. One thing we do worry about and are concerned about is that visualization here can be quite difficult. So making sure that you are able to see as you incise the endopelvic fascia, making sure that you can see this shoulder right as you get to the puboprostatics is quite important to see and to understand. Visualization here and really manipulation, being able to feel the borders of the prostate as you're going around is quite important. The big thing, and this is where people get into a lot of bleeding, is that you can see here, right around where the puboprostatics are, you can encounter a lot of blood vessels that are in that area. And if you don't have good control of this area, you can get into early bleeding before you get control of your dorsal venous complex or your DVC. And so those are important to make sure that you really clip those areas well as you're exposing that endopelvic fascia. So again, visualization, very important. So here you see this picture, the endopelvic fascia is incised. This is the prostate here. And you can see that the dorsal venous complex is pretty well isolated here, again, as you're getting along the sides of the shoulder of the prostate. The first thing to do, again, is to oversew the proximal area. This will be what we call your back bleeding stitch. And you can use any suture that you want for that. And this is where it gets really important. Really, the most, when Dr. Walsh first described the prostatectomy, the brilliance of his surgery was really in maximizing control of the DVC. Because once he was able to see the DVC and get control of the DVC well, then his urethral anastomosis, urethral dissection was excellent. Then because he saw the whole field and there was no bleeding, then the anastomosis itself was perfect and the nerve sparing was perfect. And so those are important things to understand. Again, one big thing that we use are either Alice clamps or a Babcock to be able to get to grasp the sides of the dorsophoenix complex. And what you can see here, actually, I don't see a good picture here, unfortunately. The dorsal venous complex is actually, if this is the urethra itself, the dorsal venous complex actually exists as almost like a U around it, kind of like a half circle. So when you do this, it's important to grab those sides and really bring it up to the top so that you're making sure you're grabbing everything together. So that may be another source of bleeding that you may encounter. There are different timings for when people approach the nerve sparing. I usually recommend doing it earlier on. So when you have the DVC controlled, then you can kind of go from the apex, starting from the apex down laterally to the side, and really getting to that layer posteriorly, which you can dissect out with either a right angle clamp, or you can use even a syringe to dissect out the layer well. And again, really the dorsal venous complex is this whole layer that I'm circling right here. Some people advocate going for what we call a higher release, meaning releasing the nerve bundle up here. But most surgeons that you find would actually just go for this corner part right there. And again, you can appreciate the anatomy here of the neurovascular bundle kind of on that posterolateral side of that of the prostate. And again, this is another way of seeing it where you can see the kind of urethra and then this neurovascular bundle being right at that corner over there. And this is really what we're trying to resect or to shave off it while not getting into the prostate itself. So once you have the DVC, the urethra transected, it's really important to make sure that you get really good urethral length. So the number one factor for continence in men undergoing a prostatectomy is, in addition to age, there are comorbidities and everything, really the urethral length. That is the one kind of modifiable factor that is very important for this. So making sure that we can maximize that as much as possible is very, very, very important. And again, as you can see here, after you go through that, you can really, pull up on the apex of the prostate and get the neurovascular bundle off. Again, we can see here, once you have that urethra kind of dissected off, again, you can oversew that dorsal venous complex so that you get really good control with it. But again, that is an area where you can run into some unanticipated bleeding. The other thing that's important too is that sometimes for some men, this is quite difficult, but I usually recommend, again, as long as you have good control of the bleeding with the dorsal venous complex, you transect the anterior side of that urethra, and then from there, you're able to place your first couple of anastomotic stitches or sutures into the urethra, and so that you can see the mucosa. You really want to emphasize the mucosa to mucosa anastomosis for that. Once you have that secured, really almost the fun part of doing the open prostatectomy is you're really able to hold everything in your hands and retract it and feel everything as you're dissecting through. And once you have that, you can really pull back on the bladder and the prostate itself and then cut along. And again, these are pictures showing exactly what I talked about, where you can put that first urethral anastomosis right at that 12 o'clock position, and then all the other sutures on the other side. And again, once you have that off, then really getting this apex off from the neurovascular bundle is very important. And as you keep pulling along, you'll run into the non-VAs. You'll be able to see the rectum as it's coming along. There are always 2 or 3 little pedicles that are right towards the lateral and kind of base of the prostate that you'll encounter. So it's just important that you just make sure that you clip them, or you will run into some pelvic bleeding. Again, this is kind of looking at the blood supply for this. And again, usually there are 2 main kind of branches that you're looking for, but this is really to emphasize that the blood supply to the prostate is quite diffuse. Then as you're pulling back, and then as you're pulling back up, you can really start appreciating where the anatomy is in relation of the prostate to the seminal vesicles. Remember that right at the base of the seminal vesicles, or right at the tip, there will always be an artery that's right there. So it is important to make sure you get a good clip, good ligation of that blood vessel as it's going there. Again, once you kind of get in and out, you can really start dissecting. So once you have that posterior side up, some people actually go from the posterior up. I really do think that once you have that secured and have it underneath, have that approach underneath and have it fully in your hands, then you can start dissecting out the anterior part of the bladder, start going down, dissecting that through, and then really connecting the 2 dots from the anterior to the posterior side. As they are doing over here. And the reason that's helpful is, again, you can get this through and through control of the prostate so that you can really retract up. And again, this is just showing the kind of the location of your seminal vesicles as you're there. And again, the main concern with this, with an open surgery, you don't need to worry as much, but sometimes with a higher risk disease, you have to be careful of where the seminal vesicle is in relation to the ureter of the bladder as well. One thing that Dr. Walsh has always advocated for as you're doing a bladder neck closure is really to evert the mucosa of the bladder itself. And he found that when you do this, that you're really able to control or reduce the risk of bladder neck contractures and strictures after this. So it is important. It only takes a couple of stitches to bring the mucosa of the bladder out so that you really get that mucosa to mucosa anastomosis. And again, there are many different ways that people bring the urethra together. Some people advocate for 6 and 12 o'clock, and then 4 other stitches in between. Other people do it at the 5 or 7 o'clock position. To be honest, as long as you're getting all of your sutures all the way down to good mucosa, then that's really all that matters. Again, as you're bringing these through, it's really important to make sure you're keeping the sutures well together so that you're really bringing things all the way together. And that's going to be very important. Usually for catheters, for an open surgery, I would leave it in for 2 weeks. The robotic surgery, I usually leave in just for 1 week. So I'll take a pause there and just see if anybody has any questions just about the surgical aspect of this. And then if not, I'll proceed with going forward with the remaining of the discussion on advanced prostate cancer. So advanced prostate cancer is really about how we manage androgen deprivation in its many different ways. One thing that I noticed too, just in my research about Mongolia, is that in a lot of areas, access to a good radiation center may be quite difficult. So I don't know if there are different radiation centers in Mongolia. Again, I do know that the medicine and the facilities there are quite advanced. So we are using local prostate radiation a lot more for advanced prostate cancer and using it in combination with androgen deprivation therapy. The studies have shown that there is some synergy there, but sometimes access can be quite difficult. Surgical castration, we do know, is quite immediate and quite impactful in terms of how quickly it drops your testosterone, and in terms of how people are, able to live with it, and in terms of its efficacy. And again, the main concept for medical castration, as we know, is really to stop the effect of testosterone. And one of the biggest ways, or some of the biggest ways that we have of doing that, are with antagonists of the GnRH, gonadotropin releasing hormone, or with either LH agonists. And we can talk about that. So again, these are the main things that we are looking for. The main goal of stopping the receptor for testosterone or androgen. And different ways that we could do that. There are LHRH agonists, for example, goserelin or leuprolide. In the States, we use those probably the most. There are LHRH antagonists, degarelix and relugolix, which is the newest one, which is the oral formulation of a GnRH, of a LHRH or GnRH antagonist, which is quite fascinating. Also, just stopping all androgen synthesis with abiraterone and some of these stronger anti-androgens, including bicalutamide and enzalutamide. I should have put that down there. I apologize. So the main things with this, as I'm sure that you're also very familiar with, is that each step of our of the methods that we have to reduce action on the androgen receptor really affects different things along the testosterone or the androgen pathway. So again, with your LHRH antagonist, it can stop the receptor here. Orchiectomy reduces the production of androgen. Any of your local anti-androgens, again, will block the receptors locally. And with the GnRH agonist, eventually it'll overstimulate those receptors, leading to an initial increase or surge, followed by suppression of LH that results in the suppression of testosterone. And again, as we know that one of the big problems that we see when we do use agents, for example, leuprolide and et cetera, is that we do have to be careful of that surge. So pre-treatment, usually with bicalutamide, or any of the other anti-androgens for at least 2 weeks before, again, is recommended to help decrease that surge. Again, these are the anti-androgen receptor blockers, which block the activity of the androgen linkage to the receptor, which then brings it to the nucleus to perform all its functions. And so the two biggest ones that we do use in the States that have really revolutionized how we handle, especially the more advanced prostate cancer, is abiraterone and enzalutamide. Abiraterone being with multiple inhibition of different sites of androgen synthesis, and enzalutamide having a very high affinity blockage of the androgen receptor. So nowadays we are using both of them, and there are very good level 1 randomized trials showing that we should be using these abiraterone and enzalutamide much earlier in the treatment paradigm for advanced prostate cancer. So for the castration naive or the hormone sensitive prostate cancer settings. And again, remember, it's important that we understand the definitions here, that castration really refers to the serum testosterone being less than 50. So it's important that each time we check the PSA, we also check that testosterone level. Also, how we treat metastatic disease, so metastatic castration sensitive prostate cancer versus non-metastatic can be different. And some things to know about androgen deprivation therapy in general. So In general, we don't recommend using these for primary localized prostate cancer. That really, those should be either treated with surgery or radiation. There is synergy with using hormone therapy or androgen deprivation therapy with radiation. We've seen that in multiple different forms. Castration itself can really be done with an LHRH agonist like leuprolide or a GnRH antagonist, for example, dagarelix or relugolix. Again, combination seems to be better than the LHRH agonist alone. There's some debate about that, but the newest evidence seems to suggest that combination therapy is better. Again, when we're thinking about which has the quickest decrease of testosterone level, really that's the surgical option. So for example, if you have somebody who's in crisis or has spinal cord invasion or something other, surgery with bilateral orchiectomy really is the fastest. Again, remember, LHRH agonist causes a testosterone flare. And then when there's prostate cancer recurrence, if they're after primary treatment, when to start the hormone therapy really is unknown. Also, we don't know when to stop the androgen deprivation therapy. The other problem too is we don't know what to give first, second, or third. So really the sequence, the timing, all of these things are things we have to study more. Finally, I'll talk a little bit about the toxicities here. The toxicities of androgen deprivation therapy are really significant and occur in almost 90% of men. So again, what can happen? Anything from hot flashes, weight gain. You can have significant psychiatric or mental side effects, mood disturbances, depression, in addition to all the other ones that we know about: fatigue, low libido, erectile dysfunction. These are all things that can happen and do happen in quite a large amount. So it is something to know about. Again, the biggest things to worry about: anytime anybody is on androgen deprivation therapy, you have a 50% increase in bone fractures, about a 30% increase in heart attacks or MIs, myocardial infarctions. You have a 10 to 20% increase in the risk of stroke, weight gain, worsening blood pressure issues, and more than 50% have hot flashes. And the other thing to note too is that about 40% of men, all the men that we treat, will have disease progression. And once you start the hormone therapy, you can reach a castrate-resistant state within about 1 to 3 months. This is important because the median time to survival for castrate-resistant prostate cancer is about 30 months. So it is something we have to be very, very careful of. So again, when we talked about prostate cancer, we talked a little about prostate cancer, Mongolia and Asia itself, the importance of PSA screening, talked a little bit about the surgical management and certain tips to watch out for. And we talked a little bit about advanced prostate cancer in terms of what we can do, some of the pitfalls that we see in terms of management and care. So I'll leave it there for questions. And again, thank you so much for your time and attention.
Thank you.
So if there are any questions, I could leave it open for everybody, or if anybody wants to use the chat or the message here, that's something we can go through as well.
Okay, thank you. The lecture is so interesting. There's a lot of the neat things, and there's one question I have to say in English. I forgot. Just wait a minute. In advanced cancer, do you prefer to do the local surgery or just to do the chemo or ADT therapy?
Yeah, very good question. So if there is locally advanced prostate cancer, so if I do see high risk cancer and they're young, then I do think doing surgery first can be beneficial. This is where it gets tricky. If it's metastatic, or even if there's node positive disease, The studies show that doing hormone therapy or androgen deprivation therapy with radiation is superior to androgen deprivation. The problem is we don't have those randomized trials showing that surgery with radiation is better than radiation by itself or radiation with androgen deprivation. I personally do think for younger, healthier people that doing surgery in locally advanced prostate cancer is beneficial, but it can be difficult, and the patients have to be aware that there will be at least temporary incontinence for at least until they regain their sphincteric control. So I do think it can be useful. I do think it provides benefit, but we have to approach it quite carefully.
Oh, I see. What about the brachytherapy in prostate cancer and advanced cancer?
So very good question. So brachytherapy by itself, when we're talking about the seed implantation as a monotherapy, tends not to be very, it tends not to be as curative as standard external beam radiation therapy or SBRT or IMRT. What is different is if you use combination local brachytherapy with external beam boost. So that does seem to have benefit for patients, especially with higher risk cancer. So I do think that that can be beneficial. Most places here in the States, you can use low dose rate, like meaning seed implantation, but actually high dose rate with catheters is quite useful for brachytherapy. And so that those are different things to consider. The one thing you have to counsel the patient on is that any brachytherapy, no matter what it is, you will always have higher risks of urinary irritation or bother afterwards. So you do have to be careful.
Wow, I see. Thank you. За манайхнаас өөр асуух асуулт нөө түрүүлжлэх хавдрын талаар асуух асуулт яг одоо асуугаад яваарай. I will ask my colleague, if you have any question, please ask in Mongolian. I will translate it.
Yes.
Манайхаас асуулт байхгүй юу? Манайхаа сонсож байгаа юм байна уу?
Надад байна.
За асуугаарай.
Ингээд асууж байгаа. 3 жилийн өмнө одоо артикал хийлгээд одоо PSA 0.1 байгаад байгаа. Ямар нэгэн эмчилгээ шаардлагатай юу гэдээ асууж байгаа.
Okay, I have one patient and who has underwent to the radical prostatectomy 2 years ago. Now the PSA level is decreased. Level is in 0.1 milligram deciliter, and we didn't have any chemo or the post-operation target therapy. And do we need to have another target or chemotherapy?
So after the prostate was removed, the PSA level went to 0.1. Is that correct?
Yes.
Yes.
No, 0.1.
Yeah, as long as that PSA stays below 0.2, then there's no need for any other additional therapy. Once it starts climbing back up, then we have to consider if we should do salvage radiation. And these days in the States, if there is radiation, we usually combine that with about 3 to 6 months of androgen deprivation therapy.
Oh, okay, thank you. Ямагч ойлгосон уу? Ерөнхийдөө 2-оос PSA level 2-оос бага байгаа тохиолдолд нисэл хийгдсэн тохиолдолд дараагийн ямар нэгэн хийм болон бай эмчилгээний талаар юм яригдахгүй, шаардлагагүй гэж байна.
Ок ойлголоо. Баярлалаа.
Thank you. За өөр асуух асуулт байна уу манайхаа? Okay, we don't have any question. Dr. Lee?
Okay.
Yeah, that's the really interesting the topics that we have, and I'm a little busy, and I will re-watch the recording again. If I have any question, further question, I will ask you later. Is it okay for you?
Yes, and please send me the email about that 22-year-old, the young person.
Yeah, for
Um,
sure,
I-
for sure.
Yeah, and I do think doing surgery is helpful. I hope,
Uh-huh.
hopefully, if COVID goes away, or at least goes lower, I can visit Mongolia again. I really enjoyed my time there about 7 years ago. So hopefully, I can see see the
Yeah.
country and see you again.
Yep, see you then. Thank you.
Okay.
Maybe tomorrow morning I will let you know about the 22 years old, the prostate mass patients data.
Perfect. Very good.
Thank you,
Okay,
Dr.
thank you.
Bayabatar, for
Okay.
coordinating.
Thank you.
And
Thank
thank you,
you.
Dr. Lee.
Thank you, Ashley, for organizing this amazing lecture.
Thank you.